Welcome, everybody. My name is David Terrell. I'm an infectious disease doctor at Unity Point here in health and clinics here in Iowa. I'm based in Des Moines. I'm joined today by Dr. Fernandez from Jackson Memorial Hospital. He's a transplant pulmonologist and intensivist. We're going to be reviewing today this new modality of next-gen sequencing in bronchoalveolar lavage, or BAL. So, particularly immunocompromised patients, we're going to talk about the test platform, and we're going to talk about some high impact cases that we both shared. Next slide. So, what is microbial cell-free DNA? Probably the term explains itself. It's microbial DNA that is from living or dying pathogens that is detected in plasma, but it can be detected in other body fluids. Particularly, we are looking for DNA sequences in certain compartments of the body. And we're looking primarily for pathogenic, but also sometimes commensals. Mostly is organisms that are present to some degree in human plasma. As you can see, there are other cell-free DNA that can be detected by this technology, fetal DNA, transplanted tissue DNA, and it's also used in oncology. So the Karius test it involves collecting a specimen, primarily as sure most of us probably, maybe not all of us may be familiar with the test. Plasma testing has been available for quite a while. Usually involves drawing blood and then it's separated into plasma. We isolate. So the step one is, of course, processing. That's quite after collecting the specimen. And once the step is processed, then the sequencing happens. It's next generation. And once that process continues to occur, then the next step is moves into identification. That usually is, very analytical, data analysis, bioinformatics, that really continues to identify and analyze the data and uses, already established platforms or data that we already have to compare to our previous analytics and give a report. Usually the turnaround for the test, once it starts the process, is about 18 hours. Now that we have the BAL, it's pretty much a similar process in terms of collection. We use about, instead of 5 ml of blood, we use about 1 ml of BAL. So the Karius test has definitely not been here just recently. It's been out for a while. I can recall even when I was in fellowship around 2018 to 2020, I was just introduced to the test by some of my attendings. And this is a test that, at the beginning was pretty rarely used, just uniquely used, but it's been, as it has expanded its utility, its diagnostic utility, it has expanded into what is today, this year when Focus BAL was launched. Karius test has a new name. It's called Karius Spectrum. I think that was just sometime late or earlier this year. And Focus BAL is a new modality in terms of what the company is offering for metagenomics. So usually this is what we get. Our institutions get a kit, and through this is pretty simple. We process the specimen within our labs, and the kit allows us to submit this and ship this pretty much overnight. Initially, we were, Karius Spectrum was the product that we were primarily using, but starting this year, now we have the Karius BAL, Focus BAL. And as you can see, the plasma test does offer quite a variety of pathogens, and the BAL platform actually offers about 500, which it speaks to, unique detection of pathogens in the respiratory tract or that are pertinent to our immunocompromised populations, specific as it stays, that is specific to lung infections. So I'm sure that throughout our training for med school and still to this date, we still our patients that are immunocompromised undergo quite a battery of testing, starting from some of the most rapid testing on BAL, but also in plasma. We do invasive and non-invasive testing. That usually entails a significant number of technologies, platforms, including labs. It could be local, our local labs, but for instance, we have to send some of this testing to reference labs, and that is quite a process. But it's not unique to us. It's most institutions experience this. And as we can see, this is kind of the timeline about how usually the tests are collected and then reported. And Karius actually kind of, it's falls around the early days usually of diagnostics, especially for patients where our suspicion is pretty high for infection. This is something that has been previously presented and discussed in terms of what is the best time, and we can always talk about this for later on in the presentation. So the standard of care testing for pneumonia, it has a variable yield, and I think we are all keen to the fact that this is quite what we see every day. Usually, our testing could be at best, 30 to 40% sensitive, and it's affected by a lot of factors, by patient-related factors, other issues that we could encounter in the patient care. About 30% of patients, in the pickup study actually had a pathogen identified by invasive or non-invasive testing. Um, as you can see, almost 70% where there was no detection. So I th- Karius introduced this Focus BAL. I think it was in a response to from physicians like us that we were requiring this technology to help with our diagnostic conundrums, with our complex cases or situations. From our experience with plasma, I think we had already a good experience in certain populations with plasma testing. So the BAL definitely seemed to be the most logical next step in terms of evolving metagenomics and diagnostics for a population. So um, Karius actually offers about a 500 pathogens um, as part of their sequencing testing, and is designed for broad detection. So, and this was kind of validated just this year in ASM. I'm not going to spend a lot of time here, but this is something that where they use analytical data to actually validate the results, and they actually use a subgroup of the pickup study to actually do the clinical validation. And what they could see is that definitely Karius tests increase about 40 to 50% in addition to the standard of care testing. So there is definitely an increase in the diagnostic yield of Karius BAL when the standard of care is negative. Now I know there is from our limited experience right now here, where we are using Karius BAL here at Unity Point in my hospital, we're definitely seeing that difference. We definitely are seeing detection. However, sometimes we do tend to see, respiratory flora. However, it's still early stages. I think we're going to continue to learn more about this test, but it is reassuring at least that we are seeing significant concordance between the standard of care and the Karius testing. And in addition to that, we also have the possibility of increasing the ability to pick up some of this difficult to grow at times or difficult to detect organisms by other technologies. And this is the list of pathogens. It's a big, congested and congested slide. So I'm always curious about some of this, difficult to grow organisms. As you can see, mycobacterial organisms are here, Legionella and nocardia organisms, as well as other pathogens, parasitic organisms, viruses, and just to clarify, DNA viruses, of course. So I won't spend a lot of time. Those ones are marked in red are the ones that we would detect with other rapid test technologies such as multiplex PCR. And this is usually what we would get with the report. If you're familiar with the Karius spectrum test or the plasma test, we usually would get a report that would look like this. This report, I remember seeing it when it was, a certain way, has definitely evolved to kind of help us to give us an interpretation, and at the same time also to kind of differentiate from organisms. We sometimes and will get quantification on this reports. The significance of this, I think, is something to be discussed in a different probably presentation, but definitely we do take all the information that is presented to us in this report, and it's really quite available. At times we can actually get this report even before it's sent out to us live. I'm going to hand out this presentation time to Dr. Fernandez.
Thank you, David. Thank you for that introduction, and thank you, Chess, for the invitation. And it is really a pleasure to share what has been really our clinical experience as a lung transplant center here in South Florida. We would like to talk a little bit about how we've been using the focused Karius BAL. So as you can imagine, one of the clinical indications that we've been using the Karius BL is for, of course, our patients that are immunocompromised, where you're suspecting a respiratory infection, where you're suspecting as well that you might have a pathogen that might not be easier to identify, or a pathogen that it will take a long time to grow, like a mycobacteria, and especially in patients that are risk factor for having aspergillus or other atypical or infections that might not be common in the immunocompetent patient. And this is really the population that we've been focusing and doing these Karius BAL. The other unique way of using it is our surveillance for potential donor-driven infections that I'm going to comment on the next slide. So when we start this relatively new transplant program in Miami, we started seeing that there was really an increased rate of infections that were not expected for places that particularly I trained, like in Canada. We start seeing an increased rate of mycobacteria here in South Florida, in addition to mucoinfections and aspergillus, which was clearly more prevalent than my previous experience. So we early on in the establishment of our program, we decided to start with an approach that will be testing all our transplant recipients at the time of the operation, right after the explants get removed, and after the new implantation of the new lungs, we'll do a bronchoscopy in the OR. We'll be very, very careful about isolating cultures and sending galactoman. And what we at that point thought it was a good, a good way to detect other pathogens that might not be easy to grow on BAL. So we relied a lot of the broad range PCR sendouts, usually looking for mycobacteria that might take a long time to grow, in addition to mycoplasma that are really difficult to isolate in our pre-transplant patients. And our experience after seeing a few patients is that we were able to detect some of these patients, but the diagnosis was really delayed. We found a lot of patients with mycoplasma or mycobacteria infections in the perioperative post-transplant period that really that delayed in results, including having these PCRs back in 7 to 10 days, was really not the right timing for us to start preemptive antibiotics in someone that is very sick, recovering from a surgery, in addition to the augmentation of immunosuppression and the high levels of immunosuppressant that we use, in particular in our patients that are highly sensitized. That's why after experiencing with these delays and really not having an optimal experience by detecting pathogens by broad range PCR, we decided to implement the Karius Focus BL, and in a way that it will be giving us more meaningful results and easier and faster results. So far experience was that connecting up to 60 patients with Karius BL in the perioperative period, we were able to detect these results early, on average between 1 or 3 days. They give us a good timing to start broad spectrum antibiotics or change our standard prophylaxis time medications. We typically will use vancomycin, cefepime, or patients have a lot of pseudomonas, and there's like a Staph aureus in our patients with advanced lung disease. And really the results allow us to really modify these antimicrobials for pathogens that otherwise wouldn't be captured. So mycoplasma, mycobacteria abscessus that are linked with worse outcomes post-transplantation, in addition to other pathogens like nocardia or stenotrophomonas that will really make us deviate completely from our standard cefepime in order to offer good outcomes post-transplants. I'm going to comment on a case. This is just one particular case that I found very helpful to really emphasize the importance of early detection. This is a 71-year-old male that was diagnosed with a pulmonary fibrosis, advanced lung disease, after recurrent exacerbations, oxygen requirements, chronic respiratory failure, and evidence already of pulmonary hypertension. Decision was to appropriately list him for lung transplantation. This patient underwent a lung transplant in the summer of this year and recovered initially very well. And of course, you can see that at the time of the offer, we do have some information about the donor. We see this donor got admitted early June with negative cultures. And as we get more information for the donor, we really discover that we have a BAL or respiratory culture actually positive for Serratia, which of course allow us to start early antibiotic, not only after transplant, but pretty early when the patient gets to the hospital for their transplant. So our standard prophylaxis in that particular case, cefepime and vancomycin, was thought to be sufficient in order to offer treatment for this potential donor-driven infection. One of the things that we encountered was that really Karius was helpful in identifying these pathogens. So we can clarify here the patient has Serratia in the bronchoscopy that was really treated with cefepime, but then we quickly identified within I think this was within 2 days after the transplant, that the patient also have Mycoplasma hominis, which allows to quickly start antimicrobial therapy that otherwise would have been initiated if this test wasn't been sent. These pathogens can be potentially detected with broad range PCR as well, but we already were struggling with the timing of the results coming back to us, which was really a big upgrade after we moved into the Karius Focus BAL testing. And you can understand the implications about testing, and not only testing, but detecting and the early treatment of these potential life-threatening infections, because there's particular pathogens that are being linked with worse outcomes post-transplantation. In this case, I emphasize the case of Mycoplasma hominis, which is being really linked not only to life-threatening conditions like hyperammonemia syndrome in the early post-lung transplantation period, cause of death from serial edema post-transplantation, but also associated with life-threatening complications like anastomosis dehiscence and persistent shock. This is just to emphasize that the early initiation of therapy is key, as multiple case report, including a data that we will presenting next year on early identification of mycoplasma, has really decreased the risk for these complications if the treatment is initiated early, only possible with early detection of these really, really hard to identify pathogens. And with that, we saw the patient did very well, completed dual therapy with levoquin and doxycycline. This patient never had any issues post-transplant. Anastomosis was good, no hyperammonemia issues, with an excellent lung function after transplantation. And this is just one example of multiple patients that benefit from this testing in our experience. We can go back to David now. Thank you.
All right, thank you so much. I do appreciate this case. So I am going to also share a high impact case that we have all shared here within my department in infectious diseases. It's definitely a big multidisciplinary approach. It's a patient with necrotizing pneumonia and lung abscess. Next slide. And one thing I would highlight, pretty different, and I know this is probably going to be, contrary to what we had already talked since the beginning of the talk, which is the use of the test in immunocompromised patients. This is actually an immunocompetent patient. And this is someone that we are currently taking care of. My partner, Dr. Al-Salman, I'll give credits to him, that we are all took care of this patient. And we are, we were definitely very surprised by this case, but I will definitely highlight the importance of the test, potentially even for immunocompetent patients towards the end of the presentation. This is a gentleman, a 44-year-old gentleman, probably known to our group and the other infectious disease group in town for previously treated tuberculosis. He actually was treated twice due to concern of reactivation, persistent lung findings over a period of months to years, and recurrent admissions for respiratory concerns, usually cough. he had actually had been diagnosed with cavitary pneumonia and had undergone multiple testing for other causes of cavitary disease, including invasive fungal infections. Even in the last 2 or 3 years ago, he was actually treated for aspergillosis with voriconazole after a test had suggested that this could be the etiology. However, he presented also early this summer due to persistent worsening of symptoms and radiological findings. At that point, my very astute partner considered that there could be bronchoalveolar as a possible diagnosis, but also other possibilities. So we actually coordinated a new bronchoscopy with our pulmonary partners. And this is, CT scan from about a year ago, or less than a year ago, probably 6 months prior to the patient presenting to our institution. At that time, he had a bronchoscopy. You know, this is like a very delicious case for infectious diseases and pulmonary. I mean, this is clearly a cavitary disease with intercavitary lesion. So we're thinking about, could this be some form of fungus ball? This patient at that time underwent bronchoscopy with negative Coulter's pathology, which I will talk about in briefly. Did not really reveal anything significant or anything that will help us in the differential. The patient then presents now with, as you can see, a more thickened cavity in the right upper lobe. Next slide. I think, at this point, we always will think in someone who had TB that this could still be TB. That's kind of always the notion that we always have. But it was interesting because after multiple testing, traditional testing, molecular testing, and pathology, we did not came to a specific conclusion. It's very likely, of course, that this is just a chronic cavity, and this is just getting superimposed infection. The pathology did reveal acute inflammation with discriminated pneumocytes and hemorrhage. There was no granulomatous changes or malignancy. The AFB stains and fungal stains were negative. Next slide. As you can see, this is our latest bronchoscopy, mixed respiratory flora. There was definitely growth of Pseudomonas fulva. Patient had already been treated empirically. This was definitely not believed to be, this was actually in culture, of course, and this was not believed to be the actual pathogen, but the histoantigen in BAL was 0.21, pretty low for what we typically will see in terms of fungal testing, fungal markers. All the rest of markers return negative, including histoantigen and in serum. The rapid test of the film array actually returned with H influenza, and the patient was actually treated with antibiotics previously for this. But now the new pathology is showing actually abscess with necroinflammatory debris. This is actually the result of the spectrum, the plasma test. As you can see, we're seeing a mixture of. This is an example of the report that you would get. Microbes with pathogenic potential. Most of what you see probably there is organisms that we would probably deem respiratory organisms, and not necessarily pathogenic. But then we organized and arranged for the send out of Focus BAL. This is probably one of the most high impact kits we have so far. We started using the Focus BAL earlier this year, and we detected Streptobacillus moniliformis. I'm sure some of us also call it. I'm sure it's also called, not me, but everybody calls it rat fever out there in the world. We also detected respiratory flora and other organisms like H. flu with a potential for disease. So doing further inquiry, this is not something I think we were really expecting from the history. Typically we would think this would be a superimposed, cavitary process with, fungal infection or a microbacterial process. But looking back and talking to the patient, actually, we found that the patient had ran over some dead rats with his lawnmower. So this is, a very unique case of Streptobacillus moniliformis pneumonia. Usually we will see more likely, in rat bite fever, usually is more likely skin and soft tissue. So this was, this continues to be a case that is actually being prepared for further presentations down the line because it's still in process. We're still caring for this patient. And actually the patient with discussions with cardiothoracic surgery later underwent right thoracotomy. So our diagnosis was, chronic cavitary pneumonia with new abscess and superimposed Streptobacillus moniliformis infection. So, and I know this is kind of a little bit, out of the, what we typically would think about sending, next gen sequencing, but this is a very unique case where our pretest probability for infection was quite high. We do think that, aside from patients that are high risk for infection, we do think that, even a small group of immunocompetent patients where there is, limitations in the available technology, that next-gen sequencing is definitely, designed to fill that gap. However, most of our patients that we think about Karius, and looking back in our own practice so far in adult infectious diseases, about 3/4 of the patients we've sent out tests this year are immunocompromised, either solely organs or hematologic malignancies. A few patients in our own experience were HIV patients, but also we consider the ideal patients to be patients of high risk for infection, where our pretest probability is pretty high, and then we can use sometimes case triggers. And I know this is just a list, to think about this test. But to think about, patients where the standard of care testing is just limited, or we cannot, or we more commonly, actually, we just don't have available invasive testing because of contraindications, because of limited access. Um, Also, to think about, when we're considering organisms that are fastidious. I live we are here in the Midwest. We do have a high rural population, so we sometimes will think about, things like this, a rat fever. We'll think about tularemia, and others. So we sometimes, and we actually diagnose patients. Well, not with BAL, but using carrier spectrum, but not to take away the role of traditional testing with serology and blood-based testing in cultures. But definitely one thing that Dr. Fernandez had already alluded to is the fact that the test, it's quite rapid. It is an advantage, especially in our high risk populations and immunosuppressed patients, when you're able to actually get an answer quick, to make decisions quick. And we don't know yet if we are making a difference, but I do presume and do think that we probably are making a huge difference by early detection, and making a positive impact in our patients' care. And this is a study that was just presented in CHEST, comparing standard testing versus standard testing plus CARES testing. I think there will be more to come on this. Finally, the focus test is rapid and can actually help identify the etiology of pneumonia in a great subset of patients, but mostly, in high risk patients where our suspicion for infection is pretty high. For like Dr. Fernandez alluded, for transplant patients, for early diagnosis and early detection in the setting of in the peri-transplant period. So it is a test that is convenient. It's comprehensive because of how the wide variety of organisms it can detect, and rapid. It's pretty rapid. I think that's one of the things that separates it right now from a lot of the standard tests that we have available. So, all right. And I want to thank everybody for being here. I want to just kind of open the mic for Dr. Fernandez for one. So if you have anything to add, any questions or anything would like to add.
Thank you, David. I think we're all, learning a lot about this as we use it, and I've been seeing some clinical benefits in patients with early detection, and really guiding our antibiotic therapy and on escalation and de-escalation both, as you're getting the results right away. In my practice, I'm a transplant pulmonologist. I'm also a thoracic intensive, so a lot of the patients that I see are transplant recipients that are in shock, in sepsis, that this is the immunocompromised patient that is critically ill. And I think this antibiotic initiation or changes to the appropriate therapy will have definitely some repercussions in outcomes when after we examine this a little bit more detail. Um, that's really all I have to say, and we'll be learning more, and of course presenting our data next year and what we do about our donor-driven infections and how we decrease complications post-transplant.
Absolutely. Yes. I think that's a very good point as well. In terms of, we always think about diagnostic stewardship and infectious diseases. So we're always thinking about, ways to, especially immunocompromised population, into how to escalate or de-escalate therapy quickly, effectively without causing, harm. I mean, I think that's the goal at the end of the day. I think this is a step in that very positive step in that direction to help us try to make those decisions in this very complex population, as as you mentioned, on the transplant patients, hematologic malignancies. Um, so we so far, as you mentioned, we also started using this test this year, so our numbers are not very high to really, from our perspective, from our experience, say there's a big difference, but we are definitely seeing the high impact cases. And I think we'll continue to, select our cases, be very mindful of the test, and continue to be very using it, and then of course cautious in terms of sometimes detecting certain pathogens. And because at the end of the day, we also, as a, we infectious, we also are stewards at heart. So as stewards in terms of antibiotics, so we really want to make sure that at times, and I would say we did have some high impact, no high impact like this, but impact cases where actually we transitioned the patients off certain therapies. We were able to transition, for example, we were suspecting, our differential was pretty uh, in the gray area. We were able to sometimes even de-escalate when, we had traditional testing plus next-gen sequencing that was allowing us to say, maybe this is either transient non-infectious or something else. So I do think that there's even a role for, for that. That being said, I did have a question. I mean, I was just curious about, I know, talking about stewardship. I did see that your patient was treated with doxycycline and levaquin for mycoplasma. I know that, combination therapy, is that something that usually, I know we've had mycoplasma patients, those tend to be very, very sick patients, in especially when they're very immunocompromised. So I'm just curious if for after you did the combination therapy, you de-escalated to monotherapy, or you did that just because you didn't have susceptibilities. I'm not, just curious.
Yeah, it's an excellent question. And, one of the things that we were so aggressive about treating it is because, we had a few patients with very catastrophic anastomosis dehiscence, that those patients were very, very sick. And so the idea to do a dual therapy was one, because, as you say, we didn't really have susceptibilities, as this was the Karius testing. And at the same time, we were suspecting if there was some degree of anastomosis dehiscence, perhaps there was a component of mediastinitis as a result of it. So we want to do upfront dual therapy. Not a lot of evidence to support what we're doing, but someone that is heavily compromised and anastomosis dehiscence, we're suspecting there might be a spread to the mediastinum. We treat these patients with a dual agent, and we stack the therapy for 4 weeks.
Perfect. Thank you so much for sharing. Yeah, I never forget my, mycoplasma patients and the very immunocompromised patients is definitely an entire different ballgame, different from what we used to see in the immunocompetent population. So, all right. Well, that's for me. So, well, thank you everybody for being present. Any questions that you may have? I see some questions in the Q&A. We will gather those questions and answer them in a outside of the presentation. I thank everybody for being here, and have a good rest of your day.
Thank you. Thank you, everyone.
Thank you.